To those of you who just joined, thank you again for hopping on. Good afternoon to those of you on the East Coast. Good morning to those of you elsewhere in the country. My name is Alex Mitchell, and I'm a communications manager with the Lighthouse Lab Services team, who will be serving as your host for this webinar today as we dive in on actions surrounding PAMA and other issues impacting lab reimbursements. We're, of course, at the end of that, going to offer some actionable steps as well and compliance items that you can check off to ensure that you're maximizing your revenue and minimizing denial management as these issues continue to swirl around us. We have two excellent speakers who will be joining Diana Williams from our RCM team today. Our speakers are with CRD Associates, a Washington, D.C. based lobbying firm that works closely with the National Independent Laboratory Association to help drive action on key issues impacting small to medium-sized labs. First, we have Erin Morton, a partner with CRD Associates. Erin joined CRD in October of 2017, bringing with her a decade of experience in global and domestic health policy. Erin's practice areas include domestic and international medical research and development funding, Medicare reimbursement, and clinical laboratory issues, coalition management, and patient advocacy training. Erin represents clients in the complicated world of Medicare reimbursement and has extensive experience engaging federal agencies and Congress. She has several years of coalition management experience, both as a consultant and within an organization. Erin leads the firm's global health practice, where she specializes in global health program financing, research and development for new global health tools, and product development partnership resource mobilization. Joining Erin, we also have Meghan Riley, a senior VP with CRD. Meghan joined CRD Associates in 2020. Her work focuses on legislative appropriation efforts for patient research advocacy groups, public health surveillance organizations, and laboratories. Prior to joining CRD, Meghan was Vice President of Federal Government Affairs at the American Diabetes Association, leading ADA's efforts on Capitol Hill to advance policies for people with and at risk for diabetes. Meghan spent 12 years at ADA working to achieve access to adequate and affordable healthcare programs for people with diabetes, increase federal investment in diabetes research and programs, and the enactment of policies that help people prevent the onset of diabetes. And then finally, as I already mentioned, we have Diana Williams, who serves as the director of our RCM Solutions division here at Lighthouse. Diana leads that department, heading up her team's day-to-day operations and helping clients stay on top of industry changes that could impact their billing and overall revenue cycle. Prior to joining Lighthouse in 2021, Diana previously served as the director of RCM for a physician group and in that same role for a revenue cycle management firm prior to that experience. She has extensive expertise implementing processes that result in increased revenue, improved efficiencies, and greater operational transparency and stabilization for her clients. Just wanted to say thank you again to each of them for joining us. I just want to touch on a few housekeeping items before we go ahead and get started. Oh, I see somebody commented that the slides aren't in the handout section. I'll go ahead and make sure that those are added to the handout section as soon as I wrap up here with my introductions. For housekeeping items, you can reduce your chance of any lag or buffering in the background if you close other applications you may have running. This webinar will be recorded. Everybody always asks, and it's going to be automatically sent out to the email address you registered under. So no need to follow up with us. That will be sent out later this afternoon or first thing in the morning when that recording is available. If you have questions throughout, we encourage you to please pop those in the Q&A section. We'll respond to them as we have time, or there will be a Q&A section at the end. If there's anything that you have for us today that you aren't able to have answered live on the call, there's going to be multiple opportunities to follow up with us either via email or via forms, both with our speakers from NILA and with Lighthouse. So please, we encourage you to reach out to us if you have any lingering questions or feel you could use some assistance in these areas. And we also run polls during the webinar. We encourage you to participate in those, but they're completely optional, just something there for engagement and to get a little bit of a better idea of the issues that are impacting our audience. And just quickly, I want to give a quick overview on our RCM Solutions and payer strategy departments. If you're struggling in these areas, reimbursements, collections, denial management, we have the expertise to help you. Our RCM Solution teams works with medical laboratories, health and hospital systems, specialty practices, and managed care consulting companies. In our more than 20-year history, we work with thousands of clients throughout the U.S., providing subject matter expertise and insights into claims, auditing, strategic planning, managed care contracting, and payer strategy and revenue cycle consulting. Our payer strategy team works hand in hand with them if you're having any issues getting in network, better understanding how to appeal to a narrow network to possibly gain entry, or just improving your overall payer contracting and diving in on those contracts and taking a look at how you could possibly improve rates there or develop a more effective strategy. Please, contact us. We have extensive expertise in that area. And with that, I'm going to go ahead and turn things over to Erin and Meg to tell us a little bit more about NILA and then dive in on some of the issues.
Thanks, Alex. It's great to be here with everybody today. Thanks for having us. We're looking forward to a good conversation. We've got some new information that we want to share with folks and give some updates on what's happening in Washington, maybe even as we speak. So thanks so much for having us. I'm glad to be here today. Before I dive in, I want to start with a little bit of background on NILA, or the National Independent Laboratory Association. For those of you who aren't familiar with NILA, we represent community, regional, and specialty independent clinical laboratories across the United States. Our member labs perform testing for lots of different types of providers and areas in healthcare, working for physicians, hospitals, skilled nursing facilities, and other types of healthcare professionals. Our members serve a wide variety of communities across different patient populations in rural areas, underserved urban areas, mid-sized cities, and other critical access hospitals, skilled nursing facilities, and other things like that. So if you want to learn more about NILA, we're always happy to share sort of who we are. We're a primarily advocacy-focused organization and do a lot of work on policy, funding, reimbursement issues across the clinical laboratory space. So happy to chat more about that. Our contact information is here on the slide if you're interested. And Alex, of course, knows how to get in touch with us. So let's dive in a little bit to talk about where things stand currently with clinical laboratory reimbursement. I think most people are familiar with PAMA, the Protecting Access to Medicare Act. This is the law that passed in 2014, so about 10 years ago now, as Congress expressed an interest in driving clinical laboratory reimbursement closer to market rates. When the law passed, it moved quickly through Congress, and it was not widely supported across the entire laboratory community. And I mention this now because I think it's important to look at where we are today in relation to PAMA. I think we're all familiar with what it's done to clinical laboratory reimbursement rates and some of the challenges that we've had, which we'll talk a little bit more about as we move on. But important to note, I think many folks in the clinical laboratory community, NILA included, were not necessarily supportive of the approach for PAMA because of the concerns of what it would do to CLFS rates over time. But despite this opposition, as I mentioned, it moved quickly and was passed in 2014. And the first round of data collection happened in 2016, which set new clinical lab fee schedule rates that went into effect in 2018. In addition to creating this kind of new payment schedule, the law also created a new category of tests called Advanced Diagnostic Laboratory Tests, or ADLTs. And these have a separate reporting and payment structure than what then became known as CDLTs, or just clinical diagnostic laboratory tests. Read all the other types of tests on the clinical lab fee schedule. And so it's important to note that distinction between the two types of tests, as that differentiates the reporting requirements and such for reimbursement rates across the fee schedule. So where are we now, right? If Congress doesn't take congressional action, we have the next round of cuts set to go in effect because of PAMA, because of this new mechanism, or not new anymore. that sort of dictates the clinical lab fee schedule. So without congressional action in 2025, we would see that next round of cuts go into effect. I want to pause here, and this is sort of I guess what I'll call late breaking update. And these two bullets are highlighted on this slide. The next round of cuts could potentially be 15% scheduled to go into effect in January without congressional action. As we speak today, actually, Congress is considering a continuing resolution, which is the government funding mechanism to continue to keep the government open. And not to get too in the weeds on this, but Congress is funded right on an annual fiscal year. The current fiscal year expires on September 30th. And because Congress hasn't come to consensus on long-term spending plan for funding each of the agencies that they're responsible for, they're going to pass what's called a continuing resolution, which will essentially continue the existing funding. So why does this matter to us? Attached to that continuing resolution is a provision that would delay the PAMA cuts for 2025. And so as we talk through some of the challenges with PAMA, some of the options for long-term reform, I want to make sure that folks understand that this is happening today as we're speaking. So we can't guarantee that this is going to pass, while we, I think, expect that it will. And we expect that this will, as I mentioned, pause or delay the next round of cuts before they go into effect in 2025, along with the next round of data reporting. Assuming this passes the House today, and then later on this evening, even the Senate, we do expect that to happen. So we're going to talk a little bit more about this as we move forward in our presentations today, but wanted to share that up front as we think about this, as I know this is a big concern for a lot of you today on the webinar, listening and kind of trying to plan within your labs about how cuts are going to impact you and what reimbursements you have to look forward to over the next year. So let's keep going and talk a little bit about some of these long-term challenges that we've had with PAMA. So, right, we talked a little bit about how data reporting happened. The big challenge here, of course, was that this data reporting process was really not representative of the entire laboratory market. We had only about 1% of labs report in that first round of data reporting back in 2016. And ultimately, that meant that it drove rates artificially low. Some codes on the fee schedule, in fact, were cut somewhere between 30 and 60%. And this meant that over the course of the first 3 years that cuts were implemented, right, in 2018, 2019, and 2020, the clinical lab fee schedule, for the most part, saw 10% cuts to a large swath of the codes on the fee schedule. One of the changes that PAMA implemented that was different from prior updates to the clinical lab fee schedule is that PAMA is code specific. So as data were reported by laboratories about their private sector rates, individual codes had different levels of cuts, right? And so some of them were cut 30%, some 35%, and some up to 60%. And those cuts were implemented over time so that we didn't have all of the cuts up front in 1 year. It was a phased in approach. And so we saw the first 3 years, 2018, 2019, and 2020, 10% cuts. And then the way that the legislation is written, in the years beyond those first 3, cuts or rates could be cut up to 15%, to phase in the rest of that total cut that was established based on those market rates that were collected. Cuts were frozen for a number of years. This started during the pandemic. And in 2021, we saw the first action by Congress recognizing the impact that this was having on the clinical lab fee schedule. And Congress actually stepped in and paused or froze those cuts in 21, 22, 23, 24. And now, as I just mentioned, we're expecting that Congress will freeze them again in 2025. And we're going to talk a little bit about why that is in relation to some of the long-term solutions that we've been talking about. And I'm going to turn it over to Meg now to talk about some of those long-term solutions, and maybe why we ended up where we are with this delay, which of course is great news overall. But I think still important that we're thinking about long-term reform to the clinical lab fee schedule, and maybe what we as a community can do to move towards that over the next year or so. I'll turn it over to you, Meg.
This one before, or in other advocacy that you may do, and that's the Saving Access to Laboratory Services Act, or SALSA. SALSA is bipartisan and bicameral, which means it's been introduced in both the House of Representatives and the Senate. Legislation that would make permanent reforms to the CLFS to protect labs from drastic unintended reimbursement cuts and ensure access to critical diagnostic tests for patients going forward. So SALSA addresses the prior discrepancies in private payer data that Erin spoke about by requiring reporting from a statistically valid sample of applicable laboratories across the entire laboratory market for widely available clinical diagnostic tests. Widely available tests are specifically those that cost less than $1,000 and are offered by more than 100 providers. So this reporting doesn't apply to ADLTs and other non-widely available tests that retain the current PAMA reporting requirements under SALSA. The statistical sample requirement would ensure that fewer labs need to report their private payer data, significantly reducing the administrative burden on labs, while also ensuring that there is no under or over reporting by any individual laboratory sector. Reporting is also required under SALSA every 4 years, whereas under PAMA, it is required every 3 years. So that would reduce the burden on laboratories as well. Though, as we know, there have been delays and freezes going back the last few years. And last, Medicaid managed care rates are excluded from the applicable data for SALSA. There is a lot of support for SALSA. It's been endorsed by more than 70 patient and provider organizations who have been working tirelessly to draw attention to this issue in Congress and make sure that laboratories are protected. SALSA's bipartisan sponsors, so those individuals in the House and Senate who introduced the bill and who are really carrying the water on it, are deeply committed to addressing PAMA cuts, and they've used opportunities in the committees on which they serve and otherwise in Congress to draw attention to this issue and to try to advance long-term PAMA reform through SALSA. There are currently a total of 65 bipartisan co-sponsors in the House of Representatives and 5 in the Senate, all of whom understand that Congress really must act to protect laboratories and patients from ongoing PAMA cuts. But that said, there are some barriers to SALSA. So for one thing, if you follow Congress at all, you know that moving any type of legislation is an uphill battle. In addition to partisan disagreements on policy and overall priorities, everything that Congress advances must receive a score, it's what's called a score, from the Congressional Budget Office, or CBO. And what a CBO score is, it's an indication of the estimated cost that a piece of legislation will have for the federal government. So how much implementation costs the government over a period of time, specifically 10 years. So the cost that's assigned to a proposal, whether it's positive or negative, has a huge bearing on where it's placed in Congress's list of priorities. Proposals that are estimated to cost the government money must be countered by policies that save money or produce revenue, which are called offsets. So SALSA has cleared one important hurdle by collecting support from both Republicans and Democrats, which can be rare. But when it comes to the cost to implement the bill, things get a little more difficult. While SALSA hasn't been officially or formally scored by the CBO, CBO did provide an informal estimate that indicated SALSA would cost the federal government more than $6 billion over 10 years. So that's a pretty heavy price tag for a piece of legislation. Without an offset to counterbalance that expense, SALSA has stalled in Congress despite its popularity across the aisle and recognition that long-term PAMA reform is essential. On the flip side, in recent years, CBO has estimated a savings for delaying PAMA cuts by 1 year. So as Erin mentioned, this has helped result in a few temporary reprieves over the past 4 or so years from PAMA cuts. So again, this year, CBO has estimated that a 1-year delay or a freeze to PAMA cuts for 2025 would save the government about $3.3 billion. So that proposal has gained traction in Congress, both to protect labs temporarily and also recoup some of the savings that can be used for other policies. So that brings us back to the action taking place in Congress today, which Erin mentioned, that a delay to cuts next year is included in the continuing resolution that we expect Congress to pass before the end of the day today. So what's next? While we note that the high cost of SALSA is a barrier to passing that full piece of legislation, and we know that there's high probability of seeing a 1-year delay before even the end of today, long-term reform is still needed. And we continue to call on Congress to really address the overall PAMA picture. And there's motivation not just from advocates, but in Congress to do this as well. Typically policymakers are not enthusiastic about a group of advocates coming back year after year to ask for the same thing. They don't want to put, that metaphorical Band-Aid on the issue at the end of every year. So stakeholders and legislators alike really know that they have to get creative and get long-term reform across the finish line as soon as possible. But, taking in all the factors that we've already talked about, a successful proposal will need to both reform the CLFS, without great expense to the federal government. So NILA and our partners, including ACLA and other laboratory groups, will continue to work with Congress on any long-term sustainable solution that will reform PAMA. It's really essential that labs, other providers, and patient groups continue to raise awareness with policymakers about the risks PAMA cuts propose. And so you can do this by telling your own legislators about the importance of diagnostic testing for patients and the irreplaceable value that laboratories bring to the communities that they serve. We're, as Erin said, excited to see that we'll have that 1-year delay going into 2025, but really that's not the end of the story here. And we have to keep working to make sure that Congress acts to address the negative consequences of PAMA. And I think that's all we have now, unless Erin had anything to add, and then we can turn it back over to Diana.
Nothing else from me. Thanks, Meg. Looking forward to questions later on.
Right.
Yeah. Thank you both, Erin and Meghan. That was excellent information and great news to hear on the delay that's going to be occurring there. It'll be nice to see that pass and know that there's some relief coming next year. But as you said, we certainly want to continue to push for that long-term solution. Along with that, if anybody would like to connect with NILA and learn more about their advocacy specific to PAMA, SALSA, or just about their overall advocacy efforts for small and medium-sized laboratories, you can go ahead and click on that offer that just slid out. It'll take you to a Google form. You can provide some basic information, and we'll provide that to Erin and Meg after the call today. Also, if you just have general questions for them or other things you want to follow up on, feel free to open that form up and fill it out later. And with that, I'm going to go ahead and turn things over to Diana. It's not just PAMA that's driving these reimbursement issues for laboratories. I think we're all aware that we're facing reimbursement cuts on a number of fronts, and Diana's going to dive a little more into that, and along with some practical items that you can do to help ensure that you're maximizing your revenue at this point in time. So,
yeah, thanks, Alex. As you said, facing reimbursement cuts in the lab space is really nothing new. It's really what I think that we can take away from Erin and Meghan's information is that it really is becoming more and more important to be proactive in implementing any best practices you can so that you are managing your labs, billing, your claims submissions, your denials very closely to reduce your risk of reduced reimbursement or clawbacks later, audits and all of that. So let's talk about what some of those additional issues are. Erin and Meghan talked about the PAMA cuts and how that hits us on the clinical lab fee schedule. every year, we see reductions to the physician fee schedule from Medicare. And as we know, a lot of commercial products in the marketplace base their allowable rates on Medicare's physician fee schedule. So every time we see a cut to the Medicare physician fee schedule or the clinical lab fee schedule, that's going to hit providers in many areas of their revenue cycle, not just to Medicare. So that's one factor that constantly drives down reimbursement. And then over the last several years, we really have seen the MolDX program and the associated LCDs and NCDs for better managing reimbursement related to molecular diagnostic services. We're seeing those policies become adopted more frequently again into the commercial marketplace. And so even those labs who don't necessarily work in a MolDX MAC, and we've got other information out there from Lighthouse about MolDX if you're interested in it. But the big thing is that even if you're not in a MolDX MAC, you are probably going to run into scenarios that are being defined for reimbursement within those MACs. So it's really important to stay up on top of all of those policies. And then the private payers are just increasingly narrowing their networks. And so especially we've seen this in the clinical lab space. We have seen this in the independent pathology space. It's becoming more and more difficult for providers to join networks, even in the case where maybe you work with a group of providers and the group is contracted. We've seen examples where adding a new provider to an existing contract is an uphill battle. So a lot of things are really driving down our ability to effectively get reimbursement, and especially with the cash flow, the cadence of cash flow coming in, all of these things are really impacting that. So some things that I'm going to touch on are going to just try to focus on areas that we can protect the revenue, we can maximize our opportunities, minimizing denials, really trying to find best practices that will save your lab money on staffing needs, and reducing the administrative costs that are associated with denial management, because we don't see this landscape becoming any easier to deal with. And so what are those best practices that can help us navigate in that space? So we're going to touch on several things today. We're going to start with the documentation requirements being first and foremost. It's a very difficult position for clinical labs to be in, that documentation requirements are so heavy, because a clinical lab is a referral-based business. You don't go out to try to find your own patients. You're not drumming up business yourself. You are receiving samples from providers. So helping providers really to understand the documentation requirements, and then within the lab itself, being aware of these documentation requirements so that you can put in some really good front end practices to ensure that we're sending clean claims out, that the revenue is going to be protected in the long run. We've got CPT codes and with the MUI or CCI edits, and I'm sorry, the MUEs or the CCI edits. And so a lot of billers are really familiar with just those general concepts in revenue cycle, that there are going to be some MUE and CCI edits. However, just putting in an edit itself to make sure that you've added a modifier, or that you drop that column to CPT code that's going to hit the CCI edits. If the final report or the medical records, the clinical documentation itself isn't actually accurate, if it's different from what you're billing out, then we could run into problems down the road. And we want to try to avoid that as much as possible. We want to make sure that the money that we're getting in the door and into the bank account gets to stay there, and we don't have to worry about somebody coming back later and taking it away from us. So the detailed documentation is just really important, and not even just for the clinical lab space, but we make a point here to call out the newer LCDs from the Palmetto and WPS Max, who have started talking about what additional documentation requirements they have for IHC stains in the pathology space. And those are commonly performed in a pathology laboratory. And so if you are in these Max, Palmetto and WPS, we've got some more information about that out there as well. But the documentation requirements in the entire lab space are becoming more and more challenging for providers to meet. And so it's important that you stay on top of those changes. Once you've got the documentation behind you, then you've got all of the practical things about how to manage your AR. What do we do with all of these unpaid balances? Do we have a patient billing policy? We are aware that during COVID, there was a need to, potentially hold off on sending things out to patients because there was a lot of uncertainty as to what the patient owed and maybe what was going to get paid through HRSA funds or that kind of thing. And so we did see some delays in billing patients. It is far beyond time now to release those statements if they haven't gone out. So once you send those statements out, what happens if the patient doesn't pay or they call to say that they don't know what this is or it's not their service? So having a good patient billing policy, a bad debt policy, how you're going to manage your adjustments and your write-offs, always key importance here. It's really important to have policies that your billers can follow and that are clear and that you maintain going forward so that you remain in compliance, but are also, again, looking frequently at what is reducing our revenue and does this make sense and what can we do to protect it differently. Some key performance indicators to watch for. So these are common key performance indicators. If your billers aren't looking for these things, we need to have a conversation. This is really kind of the tip of the iceberg. Once you start drilling down into these KPIs, you get a lot of questions can arise from these. So we should be seeing that you're sending out clean claims the first time, with very few rejections coming back from the payer saying, we can't even process this because you don't have a place of service code, or, this CLIA number doesn't match. So not only should your claims clearinghouse have those things in place, but what additional, because of your lab situation, what additional edits and modifications might need to be made so that you are potentially pausing a day or so to send that claim out in order to maybe get that pre-authorization that was missing that this payer is going to need. So how can we get that clean claim ratio increased so that your cash flow is maintained and also stable? So several KPIs. I'm not going to say each one of these. You can read the slide here for yourself. But each of these KPIs will lead you to further opportunities in your revenue cycle. Again, to identify where are we potentially losing revenue or our reimbursement may be at risk, so that we can move those findings into a front end process to minimize denials later. Here is a slide that we've talked about before in some of our webinars, just about what those effective front end processes look like. And I like to just kind of laugh when I look at this slide because it makes it look so simple. But those of us behind the scenes that have worked in revenue cycle know that there is a lot that has to go into each of these elements to make it work right. And that's where we at Lighthouse can really help. And really we do. We get involved in these conversations with our clients to help them with these front end processes to make sure that you've got a flow of clean data coming in. Your demographics, it's not just a patient name, date of birth, and address. Your demographics are the correct insurance code, the correct address for that insurance plan. Does that insurance company require a prior authorization number, and did that come to you in the data? So a lot of things in patient demographics that need to come to you. And then once you get the data in, it goes right into your charge capture and what your requisitions look like. Are you capturing all of the charges? Are you capturing the correct charges? And is your requisition form set up appropriately so that you can get all of that information right the first time from the ordering provider? In the back end, we've got denial management, and this is where, again, I see a lot of resources expended in denial management, and it's ineffective use of our resources. There's not there's some automation that can be done to manage your denials, but ultimately it comes down to people power. And what do your people know? How curious are they when something is received from an insurance company, or they notice a pattern of non-payment from an insurance company? Are your FTE resources going out and asking questions and digging into it? There's only so much that you can get out of automation, and even only so much that you can get out of the written guidance. Unfortunately, payers don't always publish their reimbursement policies, or their reimbursement policies are so vague or non-specific that you can't really make heads or tails out of it. And so this is where the people power comes in, and you have to pick up the phone and you have to maybe talk to 2 or 3 people to get to an answer that makes sense. So we want to reduce the amount of resources that we have to put towards managing that. And to think about effective denial management, not only is this going to save you costs and your FTE resources for the lab, but in the general sense of HIPAA and trying to reduce costs in healthcare, this reduces effective denial management, reduces the administrative burden on payers, on providers, on billers, and ultimately that's a good thing for patients. So we don't want to just work denials as they happen. We want to get in front of them and understand why they're happening so that we can minimize that going forward. And this is the fun of revenue cycle management. It's a wheel that never stops turning. There will always be denials. There will always be new things that come up, and we need to have those questions being asked. This is kind of talking about payer policies and procedures again, where, there are some published guidelines. There are really good published guidelines out there, not only the LCDs and the NCDs, but payers themselves publish some really good guidance as to what services they cover, what the what their medically necessary approved reasons for services are. Sometimes that information is really tough to put your fingers on, and our teams help our clients quite frequently in navigating those payer policies, and especially in the absence of published guidelines. We talked about that just a minute ago, really needing to ask the right questions and understand what's happening within the industry to make good decisions and effective strategies. Appealing to these closed and narrow networks is such a critical part now of protecting a lab's revenue. And it's something that, we have a payer strategy solutions team here at Lighthouse that really offers some interesting perspective into how we can potentially get into some of these more difficult networks, or at least have access to some of those patients. Some of the things that you can do to really make yourself more attractive to networks as you approach them to contract with them or to engage with them in some sort of a reimbursement agreement. What does your test menu look like? Are you kind of, there's a saying, I think, master of nothing, but I can't think of it right now. But having an expansive test network so that you can speak to many providers, many patients within a community, that may be an effective strategy for you. Looking at your quality and what outcomes these patients are seeing at the end, and being able to create a case study or a written narrative about how your lab within the community itself is positioned differently and to offer valuable services to these payer members. Really working on your referral, looking who your referral partners are, what services they offer, and comparing that to your payer mix and understanding, how to potentially identify really good referral partners that are going to result in that more stable revenue so that you can continue to provide additional services that maybe you have to fight a little harder for. Looking into joining accountable care organizations, patient-centered medical homes, anything again to kind of increase your footprint and your people leverage. How many people? What's our scope in the community? What access do we have that others in the community don't have? Having unique and proprietary test services can really be a way to set yourself apart. There are revenue cycle management challenges that we can help with through those development processes. So as you look at developing your tests, considering your marketplace, who your referral partners are, having that unique test can really set you apart in the marketplace if it's something that the marketplace is looking for. And then what I mean by that is that special demographic. If you have unique and proprietary tests that are geared towards, let's say, high risk patients, under women's care, and maybe you have a local service organization in the area that focuses highly on maybe, a large population of that kind of patient, then you've got yourself a really nice offering for your community and a way to set yourself apart with payers to get into their network. So some other things that you can take care of. This is mostly just really looking at everything as a relationship. Optimizing your participation, because in this relationship that providers have with payers, it's a give and take, right? I always like to say, insurance companies aren't in the business of paying claims. So they're in a business as well themselves. And so really optimizing that partnership so that there's a give and take there. Viewing them as a client and not as an obstacle or not as an enemy. Sometimes I know that's hard because these are difficult conversations and payers don't necessarily want to budge. But again, we can help with that. Watching what you send with the appeal letters when their network is closed, when they say their network is closed. Okay, but what does that really mean? And how can we, again, leverage ourselves? So just because a payer says their network is closed, I don't think that means that it needs to be that the door is closed. I think that means we keep knocking. And then we always look at the state utilization just to, what the presence is in that state, what the payers are looking for, what kind of partners they need, what are their members looking for. So then I'm just going to kind of pivot real quick to talk about the auditing that we see going on, because that's where we see a lot of difficulty in the industry right now is just in auditing. And we've been talking about this for a couple of years now. When COVID ended, when the PHE ended, we saw these audits start to tick up. I think everybody is getting back to, business as usual. Business as usual, unfortunately, has changed because of the PHE. And so as a result of all of the changes, with innovation and with technology, as well as in industry knowledge, subject matter experts changing from one role to another. And, there just has been kind of a gap between the services that are being provided and the reimbursement that you thought you had that's being taken back. So we are seeing quite a few labs undergoing different audits or at risk of government audits, CERT audits, UPIC audits. This is, again, where our teams can really help in understanding the landscape, the reimbursement landscape, and what best practices you can implement at the get-go to really minimize and reduce these risks. I recommend that you go out to the OIG's website. They publish their work plans every year to give you an idea of what they're looking at. Medicare will go out. The RAC audits, the Medicare RAC audits, they'll go out there and they'll talk about what their findings have been and where their focus is directed. It's important to keep an eye on that because you can be very proactive. By monitoring the OIG work plans, you can be really proactive in minimizing your risk for your reimbursement risk, whether it's denials or recoupments later, by being ahead of the game, by monitoring those OIG work plans, the RAC audit lists. But we are, as this says, it's not if, it's when, and audits are a huge issue right now. They're making payments, the payers are making payments in good faith. And this is where I think a lot of labs are caught by surprise is, they anecdotally will talk to Dr. Jones down the street who says, oh, I've been sending claims out this way and getting paid for it, possibly not knowing that Dr. Jones themselves is at risk for recoupments. So really understanding the rules and the trends, again, is not something that is necessarily you just go out and you look it up and you find an answer. It really is not that simple. And so wanting to understand that just because you get paid for something doesn't mean that the payer, whether it's a government payer or commercial plan, cannot come back later and take that money back if they feel that they paid in error. So really being, again, ahead of the game. If you do get notification that you're going to be undergoing an audit, really of any sort, whether it's a government, commercial payer, you need to have a primary contact within your lab to respond to that audit. And you really need to be timely in your response. The letter will tell you exactly what is expected of you, and that's exactly what you need to provide. And if you are not able to provide it by the deadline given to you by the audit organization, then you need to ask for more. You cannot just sit on these things and hope that it goes away. And the other thing, as you provide the timely response, when we say comprehensive and accurate, unfortunately, you really need to give a critical eye before you send that response. Give a critical eye to the information that you're sending to determine from that third party's perspective, what are they going to see? And is this going to actually respond to the root need here? Whatever it is that the payer is flagged as being potentially risky or inappropriate, does this material that we're providing back to them, will it answer the question? Does it accurately and completely speak to that question? And that's where if you do respond to an audit and you don't send the information that they're looking for the first time, the audit can expand, the time in that audit can expand. Your cash flow is continually, interrupted because of the audit process. So making sure that you're not only timely in your response, but that the materials you're sending are an accurate and complete support to the claim. That's important. And then you need to look for expert guidance. If you're getting an audit letter from a government entity, we highly recommend that the first person you call is your healthcare attorney to have them walk you through it. Your compliance officer should be all over these things as well. And that takes us to compliance. So I'll just stop here. These are the 7 OIG recommendations. And the one thing is that the training and education is not just a one-time thing, it's an ongoing process. So it's ongoing training and education. And we often see, not just in the lab space, but in healthcare in general, compliance is often looked at from a clinical perspective. Are we doing things appropriately for patient care? Are we safe? Are we accurate in our documentation? But billing compliance is a little different. And so we start getting into questions of upcoding, downcoding, unbundling, bundling, misrepresentation, overutilization. All of those things need to be on your radar as well, and part of your risk assessment, your compliance plan risk assessment. So that's it, Alex. Thank you.
Yeah, thank you, Diana. And again, to Erin and Meg for the advocacy info up front on PAMA. Lots of great news there. Just want to say quickly again, I don't see any questions in the Q&A as I wrap up here. If you'd like to submit any, we have a few minutes left here. But if you have any questions about anything we touched on today in terms of overall RCM health or any of the many issues that Diana touched on, we can explore those in more depth. We offer a free consultation for new clients. So please, if you have any questions about RCM or your payer strategy and contracting, go ahead and reach out to us through that form there. I see a number of you also did fill out the form for NILA, but if you didn't get a chance to use that form yet and have questions about NILA's membership or advocacy for PAMA and other related issues, you can go ahead and use that form right there. Erin, we did get one question here that is somebody submitted to me anonymously. Could we speak at all about how the math of a PAMA delay actually saves the government money? Or is that a little bit more in the weeds than we'd like to get into here?
Thanks, Alex. It's a great question. It's a little bit in the weeds. What I can say is that because the way that SALSA is written, there are caps each year on increases and decreases in the new rates that can be derived under the CLFS, and those caps are around 5% up and down. Under the existing PAMA statute, there are no caps beyond those first 3 years. And because of the inflation that we've seen over the past couple of years, past year, really, the way that CBO is estimating Medicare costs over the next 10 years sees a pretty significant increase in those costs right around 2029. And because that is within the 10-year window that CBO uses to derive those estimates, that is showing a pretty significant increase potentially in rates under existing law, again, existing law being PAMA. And so the longer that is delayed, there's actually a savings to the government by not implementing or not continuing to implement the law because of those increases in some of the later years. So that's the simplest explanation I can give. What I will say is that CBO's estimates are estimates. They're basing it on assumptions, Medicare costs over the next 10 years. They're basing it on assumptions around CPI and inflation. And so it's a little bit of kind of funny math sometimes. But we do, as Meg mentioned, kind of need to rely on those estimates that CBO puts out, because that's the best example that we have of the costs and savings to the federal government. So hopefully that wasn't too weedsy.
No, thank you, Erin. That made sense, and definitely as a layman, I was able to digest it myself. So hopefully the questioner got the information they were looking for as well. We're bumping right up against the top of the hour here, so we're going to go ahead and wrap up. Please, if you didn't get a chance to direct your questions to us, go ahead and use either one of those offer forms or email us at that info@lighthouselabservices.com. We'll get that question directed to the right place. But I just want to say thank you again to both Erin and Meghan and Nyla for their time today. Very important issue, stopping these PAMA cuts, and it's great to hear that that is expected to happen again in 2025. I also want to say thanks to Diana for joining us to share her expertise. With that, we're going to wrap up, and I hope you have a good afternoon. Bye-bye, everyone.